Next, we have a talk by Dr. P.S. Bhatt from Omega Hospital. He's the interventional cardiologist. He will be speaking on pacemaker ECG. Dr. P.S. Bhatt.
Good evening to you all. I would be brief. I think we had a long day, and mine is about pacing. Pacing has come for a long way. In the early 1950s onwards, pacing is in vogue to save patients from bradycardias, heart blocks, syncope, and tachybrady which came later on. What is pacing? Pacing means whenever the heart rate is, all the electrical activity, see we are dealing with ECGs, the electrical activities of the heart. When the electrical activities are less, bradycardias, maybe the sinus bradycardias, many times in the sixth sinus syndrome, tachybrady, you have tachycardias, how to treat them? And at times they go to bradycardia, the sixth sinus syndrome, they go like that. So then what do you do? Then you need pacing. Similarly, heart blocks, there could be congenital, that could be acquired. Congenital, some people rarely have, children have heart blocks. Similarly, heart blocks is a degenerative disorder, especially the elderly. Then you need pacemakers. Or high degree AV blocks, trifascicular blocks, or electrophysiologically if you measure HV prolongation, then you need pacing. So what are the types of pacemakers? What are these pacemakers? Pacemakers initially came with a crude thing that is called external pacemaker. They used to keep two paddles, one either anteriorly, one posteriorly. See, in the ICUs, when patients had cardiac arrest, what do you do? There is a horizontal line, no cardiac activity. Then these paddles could be kept anteriorly, posteriorly, and then switch on the defibrillator. They have external pacemakers. They are of some use, but not all effective. Then we have internal pacing. It could be temporary or permanent. Temporary, when you have, suppose, inferior wall MI patients come with bradycardia and heart block. Usually it is reversible. So in a week's time they revert. In that case, transvenous pacing is done either through the femoral vein or subclavian. You put in a lead into the right ventricle apex and pace. Connect to a battery or external pacemaker, then you can put into require rate, whichever you need. Usually the heart rate is below 40 and then there is hypotension, you need pacing. Then it could be single chambered. Either most commonly it is in the ventricular pacing. You put in the pacing lead into the right ventricular apex so that you have a ventricular pacing. But many a times you need dual chamber pacing, two atrium and ventricle, because whenever there is a horse racing, then if the horse doesn't ride, then the jockey gives it a kick. Similarly, atrial kick, the atrium contracts, it contributes about 25% to the cardiac output. So whenever you need somebody who is young, who is exercising or swimming, or anybody in that case, or in some people with a thick musculature, they get into pacemaker syndrome. Those patients, you need dual chamber, atrial pacing followed by ventricular pacing. That gives good cardiac output. That is why you need that. So this is how basically what we do. Coming to the chambers, what we have is chambers where there is a North American Society of Pacing and Electrophysiology and the British. They have the nomenclature chamber paced. That is atrium, it could be single chamber, atrium, ventricle, or it could be dual chamber, where you have atrium and ventricle, both could be paced. Then there is a chamber sensed. There is this pacing is a complex electronics. It paces, it senses, and it modulates. You can even program that depending on if you want to increase the rate or reduce the rate, increase the output, increase the refractory periods, or these are the things which could be programmed. So in the pacing, you have chamber pace, that is the first one. Next thing is chamber sensed. If there is atrial activity or the ventricular activity, these pacemakers could keep quiet, because that is why that means they are sensing the electrical activity of the person or the patient. Suppose in the refractory period, that is, if it doesn't sense properly and gives a stimulus, it could lead to ventricular fibrillation. So it is very important. The atrial sensing is very important. So with that, I means inhibited. If the atrium, if the pacemaker is sensing properly, it inhibits. So it doesn't give a stimulus. So you will have inhibited, or D means dual. It could be inhibited or it could be triggered. Whenever you need, that kind of pacing is also there. Then programmability. It could, the programmable newer pacemakers have programmability where you can program it, rate the output, refractory period, and other things. All can be programmed from externally with the programmer. So what you look for in the ECG? When there is a pacing with this spike, there will be a spike followed by that chamber will be contracting. So that will show if it is in the atrium, there will be P waves. If there is a ventricle, then you will have QRS complex. So rate, QRS axis, STT changes, these are all the things which you have to see, and underlying rhythm. See, this is the VVI pacing. V means it is in the ventricle is getting paced, ventricle is being sensed, and it is inhibited. Whenever the patient has his own rate, the pacemaker will keep quiet. So here you see here is a spike followed by a QRS complex which is wide. So this shows that is a ventricular pacing. Then if you see in the ventricles, what you do is we keep the lead in the RV apex. So you have a left axis deviation, lead 3 usually there is a left axis deviation, and the QRS morphology is like a left bundle branch block. That means the right ventricle is being paced. So from the right ventricle, left ventricle is getting stimulated. That's why you get a left bundle branch block pattern. See, it's the same thing. VVI pacing, we have the spike followed by left bundle branch type of pattern. That is the RV pacing. This is the photograph of the lead. Generally, when we do a permanent pacing, what we do is a subclavian vein puncture through which we put in a lead into the right ventricular apex. So you see that it is in the right ventricular apex. Lead is in the right ventricular apex. In case we have dual chamber pacing, then we put another lead. It comes from above and here, somewhere here in the right atrial appendage, and that moves semicircular pattern with each systole. So you can make sure that it is in the right atrial apex. And when in a lateral view, you are sure that it is pointing anteriorly because the right ventricle is anterior. This is the dual chamber pacing. D means dual chamber atrium. See here, you can see a small spike that is in the atrium, followed by another spike that is in the ventricle. So atrium is initially stimulated. After a short period, there is a time gap. There is a PR interval. So after the atrial systole, you have the ventricular stimulation, and you get the ventricular contract. So in this case, you get the full benefit of the atrial kick. So the cardiac output remains good. They don't get into pacemaker problems, and they can exercise. If you can increase the heart rate with as needed, then they can go to good exercise tolerance. They will have swimming, playing games, all these things they can do. Then next we have, these days we have single lead where we have they can do atrial sensing. So the lead is floating in the right atrium and it senses and it paces the ventricle. So you have the benefit of atrial exercise. Whenever you want to increase exercise, depending on the oxygen saturation or the breathing, this increases the heart rate. This could be, you have the atrioventricular synchrony. This is when the conduction system is all right, but the sinus is sleepy or it is not functioning properly, then you can do this atrial pacing. This is the AAI, see the stimulus is here followed by atrial contraction and a narrow QRS complex. Because the AV node is functioning all right, bundle branches functioning normally, so you have a atrial pacing and you have a QRS complex is narrow. The same thing here, see many places you see normal, the patients meet only, then there is a gap, so this is called hysteresis. After that you have the atrial pacing followed by QRS complex. Sometimes what happens is these pacemakers patients, when they will go near the large transformers near the airport or going to the kitchen in the microwave oven, then they get disturbed because there is a high activity electromagnetic waves. Those things are sensed and the pacemaker keeps quiet. This is what is happening here. Muscle twitches, electromagnetic waves, microwaves can sometimes lead to, see here it is keeping quiet because it is sensing some external electromagnetic waves there. Then once the pacemaker is failing, how do you make it out? Pacemaker is failing means it fails to sense or it fails to capture. Even if there is a beat, it is not causing contraction properly. This could be because of either there is a fracture in the lead, or this lead is displaced, or sometimes the battery is failing, or the circuitry is at fault. Then you will find that, see here it is over the QRS complex, it is not sensing properly. That is why there is a stimulus. So it is not sensing properly. Similarly, there are some see here there is a spike, but it is not pacing. So there is sensing failure and capture failure. So both ways there is a failure. This is a pacemaker problem which has to be properly recognized and then it has to be rectified. Then ultimately these batteries have a life. When we were, see, I was doing in DM that time, long back, we had mercury battery, quite big, 50 grams, and they have a short life. 3.5 years, 4 years, they fail, then you put a new one. Today, luckily, we have a smaller ones, lithium battery, come for 10 to 12 years. So how do you know that that battery is still working or not? So you can do that, of course, with the machines you can make out, but looking at the ECG also you can make out what there will be dropping at the pacing rate. Usually they will be set around 70, so they come down to 68, like that. The pacing rate is coming down, increasing the pulse width. That pulse width will be wider. Then usually we have another, what they call is a magnet. If you keep the magnet over the pacemaker battery, it works like a fixed heart rate. Even if the patient is giving his rhythm, it will go on giving beats. So that exact what is the rate you can make out. That is the magnetic rate. And of course, loss of capture and spike. Here, this is how we can make out. See, here there is a signal, but there is no contraction. That means it is not it is not contracting. That probably the battery is failing. Similarly, see, here is over the QRS, there is a spike. That means it is not sensing properly. So there is sensing failure, capture failure. That means the pacemaker is malfunctioning. This is the time to change. So basically, when postgraduates, you see, look at the ECG. There is a spike, and see what is after the spike. If there is a P wave, it is a atrial. The lead is in the atrium. It is giving atrial contraction. Look at the spike, and if you have a wide QRS, usually in the right ventricle means left bundle branch flattened. That means it is a RV pacing. Looking at that and the rate, you can make out, oh, this patient is having a pacemaker and is functioning properly, or if there is any problem, then you can, of course, refer to somebody, a senior cardiologist, so you can do the thing, whatever is needed. I think that is in brief about pacing. I think for a postgraduate to begin with, this is good enough. Then now pacemakers are used in intra-ICDs and biventricular pacing. It is a little high for you should know that heart failure, there is a asynchrony, mainly left bundle branch block pattern is there. Then you put biventricular pacing, one in the right ventricle, another in the coronary sinus in the deep in the vein. That stimulates the left ventricle. So you have biventricular pacing. So the contraction of the left ventricle is synchronized. There is a better cardiac output. There is a treatment for congestive heart failure. So with this, I thank you all for the attention, and thank you, Dr. Prabhakar, for calling me. Thank you very much.
Thank you, sir. I request Dr. Syed MK, Interventional Cardiologist, Father Muller Medical College, to hand over a certificate of appreciation to Dr. P.S. Bhatt. Thank you, sir. Next, we have a very interesting session, an ECG quiz by Dr. Martin Green. Dr. Martin Green is an internationally renowned interventional cardiologist and electrophysiologist from Canada. Sir, over to you.
Thank you. My pleasure to be here. I've come to India several times at these ISECON courses, and it's always been a pleasure. I'm going to do something completely different today. And what I intend to do is to actually start with the most difficult rhythm ECGs you're ever going to see. And what I want to accomplish is to show you that by taking a simple method of looking at ECGs, we can make complex rhythm analysis easy. It's never really easy, but it's, you know, I'm taking a little bit of a chance here because I'm starting off with extremely difficult ECGs, but I think that extremely difficult ECGs get people very afraid. And as I see younger physicians, they don't even want to touch them. They feel that this is over my head. And I guess what I want to prove to you is it's not over your head. You have to have a method of looking at it. And when you do that, it works. So let's start off with my approach to the ECG. So this is rhythm analysis, especially for complex rhythm ECGs. Firstly, do not jump to conclusions. You have to describe what you see first without making any diagnostic terminology, and I'll talk about that in a second. You have to have a system. The system has to start with a description, and it has to avoid using diagnostic terminology. For instance, if you see a QRS followed by a P, you say, I see a QRS followed by a P. You don't say, I see VA conduction, because it's not necessarily retrogradely conducted. They may not be related at all. So you first describe. You don't use terminology that is diagnostic. When you break it down into its components, you can usually come up with a reasonable answer. So, describe what you see. Describe. Remember, you have to describe. You shouldn't try to analyze too quickly. Stay away from mechanistic terminology while you're describing. Look for the edges. Look for the transitions. When you see a rhythm change, when you see a pause, when you look there, because the answer often resides in those spots. Identify the atrial rhythm. It's really important to try to figure out what the atrium is doing. If there's AV dissociation, if there's more A's than B's, more V's than A's, it's worth taking your time to look for P waves. And I would say you can almost always identify the atrial rhythm. After that, draw the conclusions that you know to be true. There are more A's than V's. Notice I say, don't say anything about VA or AV conduction. There are more A's than V's. Say what you know to be true, and then go and say, okay, now this is what we don't know. Once you know something, you can try to wean out the unknowns, so you've figured out what exactly don't I know. Then you come up with a hypothesis, a differential diagnosis. Well, it could be this, or it could be this, or it could be this. And you have to try it on for size. It's like going to the tailor. You have to try it on for size. So you say, okay, well, maybe it's this. You don't stick on that, but maybe it's this. And then you add in all the things you know and all the things you don't know, and you say, you know what, that doesn't fit very well. Doesn't work. And you try on the next differential the same way. Exclude the impossible. Once you find something and you say, you know what, it can't be that, exclude it off your list. And by doing that, ultimately you narrow down your differential and you can often come with the correct answer. Apply what you know to the differential, test your hypothesis against what you know and what you don't know. And don't forget that this can be fun. I'm trying to get the younger physicians to spend time looking at rhythm ECGs because they can be fabulous. Okay, let's go. So here is the hardest rhythm ECG you're ever going to see. Nurse calls you. They saw this on the monitor upstairs. It's easy to look at, but I can tell you that it's not always that easy to determine what's going on. So let's do it. We have a look at it. Well, what do we see? We see at the beginning and at the end, we see what looks like a sinus P wave. This is lead 2, this is lead V1, followed by a narrow QRS that looks normal. So that is probably sinus beats, and the sinus beats are narrow. What else do we see? We see a wide QRS tachycardia that is initiated by a wide complex beat that is not preceded by a P wave, but is followed by a P wave. Just a description. Notice how I said the wide QRS is followed by a P wave. I didn't say VA conduction because I didn't want to get locked into that yet. I'm not saying it's not VA conduction. I just don't want to get locked in the description phase. Then I see a wide QRS tachycardia with a slightly different morphology than the first beat. And I see for each beat, I see a P wave, a one-to-one VA or AV relationship. I didn't say one-to-one VA conduction or AV conduction. It could be neither, it could be both. Just that there is a relationship one-to-one. You see how using terminology